Okay, now in this video, we're going to talk about treating the sphenoid intraorally, which people are like, you're going to do what? And then I have to go into using the cranium, explain. So essentially the education, and this is important for clients because otherwise they're just going to, you're going to be working on them and they're going to be like, what in the world is going on? And they may still be, but at least there'll be some context. So the pink bone is the sphenoid. It's kind of like this bat wing kind of looking bone. There are or you can access it, turn it to the side through the external and through the temple basically, where you can work on shear mobilization and then turn it back. And then inside the mouth, there's these little promenii, I don't know the English on that. There's those little bumps there that you can feel if it's significantly side bent, or the biggest thing that I feel is a rotational dysfunction where these little bumps are either kind of this way or this way. But there's a chance that they could also be this way or this way, okay? Now options are you can treat on both of the prominences and try to guide the rotation, or you can treat by pulling through the yellow bone, the maxilla, pulling through the maxilla as you try to relatively decompress sphenoid, and you can see that's Kelsey's doing there, decompress sphenoid to also correct a side bend rotation dysfunction. Now, we take the top off of the cranium. The reason this is very important is if you look inside the cranium, you see the pink bone there. So the brain sits on top of this, obviously, and then you have the dura, or the skin of the brain, that surrounds the brain and then surrounds the spinal cord all the way down, right? The dura has an attachment right here on this little prominence here inside of the cranium, which is why this bone is kind of like an epicenter for a lot of things, neural tension and headaches, when it's related to that central nervous system. And just a fun fact, the other end of that dura has attachment onto the coccyx. And so oftentimes if I'm treating a sphenoid, I'll at least be checking the coccyx. If I'm treating a coccyx, I'm at least checking the sphenoid if there's tension in that dural tube, a dural system. Okay, so now when you're going to work on sphenoid intraorally, the communication with the client is important. Obviously you want consent, but also you don't want them to bite your fingers, right, if they're in pain, right? So my education typically is, okay, if you feel choky, if it feels too painful, if you feel like basically my hands need to exit your mouth, just raise your hand. And then I immediately come out. I try to make sure this is an area of the body that I treat through silence basically, because I'm really trying to be sensitive to what I feel. And oftentimes I'll close my eyes whenever I'm doing that with a client. But with this, if you have this mutual understanding, your eyes need to be open so you can see if they raise their hand up. Okay, now go ahead and open. So I'm gonna come slide basically straight back from the molars and slightly medial. Okay, so I'll come out again. So open up. I'm sliding straight back on the molars. Keep going, and then I go just a little bit medial. Okay, and so then from here I am just on those two little prominences. Try to relax your jaw as much as you can. There you go. I'm on the two little prominences, and I'm feeling positionally, does it feel like it is, she needs me out. So does it,
cough on you?
it's all right. Does it feel, I closed my eyes, and that was a problem. See, learn from me. My eyes were closed, and I almost missed that. So it felt like right side was deep, left side was superficial. So I would call that a relative right rotated sphenoid. Now, you're probably thinking to yourself, he thinks he's like moving a cranial bone, like actually mobilizing and moving positionally. I don't know, like possibly, but I believe that I am communicating with the nervous system, with the central nervous system, and trying to get the central nervous system to not hold itself or hold this sphenoid bone rigidly in this rotated position. And I'm trying to encourage the nervous system to be okay with allowing it to sit in a more neutral, balanced position, okay? But I will say my intention is movement, all right? So whether I am actually mobilizing it or it's just letting go and allowing, like whether the nervous system's doing it or whether I'm doing it or that's a combination of both, I'm not really totally sure. I just know I've done this on a lot of people, and I've learned from from people who have done it on a lot of people, and it is pretty wild some of the changes that you can make working on this bone. So I won't say that. Okay, go ahead and open. Straight back from the molars, a little bit medial, soft fingers, feeling for those little prominences. Some people, they'll be very prominent. Other people, they won't, like Kelsey. Okay, so I'm feeling, it feels like right side's deep, left side's superficial. So I am hooked on the posterior aspect of the right side, anterior aspect of the left side. Try to relax your jaw. There you go. And so now I can have her nod down, just, that's it right there. And I'm just hanging on. I feel no infill on my left hand. I feel a hard infill on my right hand. So I'm actually going to release my left hand, go to that maxillary grip, pull on her maxilla up towards the ceiling to try and decompress the sphenoid to allow it to come back anteriorly. Okay, so let's say it's rotated to the right, it's down towards the table on the right side. If I pull what's in front of it away to try and create space, it may be happier to do that. Nod your chin down just a little bit. Good. Breathe in and out. Try to relax everything as you breathe out. Good. I'm just going to guide her a little more. Right there. Nod your chin down. Good, and let it go. Okay, so essentially I'm pulling up on maxilla, pulling up on the back side of that little prominence, creating space through maxilla so that I can de-rotate that sphenoid. That's just one example. It could be side bent, it could be rotated. It could be best just to stay on both prominences, but just felt like for that moment I needed to pull on maxilla. So this is sphenoid mobilization inside the mouth. You have to note with your clients, like you may feel completely out of it the rest of the day. So if they have things going on that day that they need to be very present and be able to think clearly for, you're not doing this mobilization that day. You'd save it for another visit when they don't have anything scheduled afterwards. So you want to get their consent on that behalf, because you don't want them to like cancel a really important day because they literally like can't function and just want to take a nap afterwards. But just know that's a possibility. They need to know that's a possibility, and then know also within 24, 48 hours, but most of the time after a good nap, it's significantly better. So intraoral sphenoid mobilization to correct side bend, to correct rotation, okay?